Well, welcome to today's talk, Wednesday the 13th of April. Now I'm going to look at some data from the UK today, and there's an awful lot of COVID still around, and this is the same in Europe and the United States, less so in Africa, but certainly a lot still around in Australia and New Zealand. Not all of it, of course, being picked up. The infection rates are way higher than the cases, and that's the good thing about this Office for National Statistics data. It's actually taking a survey, so it's a good snapshot of what's there, and it's consistent with the other surveys that we've been using as well. So we're fairly confident about the quality of data, but we will be mentioning some of the data that we are not given, which is really quite unfortunate and could easily be given. But let's just start off with the overall prevalence at the moment. I mean, wow, there's still a lot around, and this is done from national, very well conducted surveys. So prevalence the week ending the 2nd of April, okay, it's the 13th now, it's always a bit out of date. But England, 1 in 13 people would test positive in that week. Wales, 1 in 13. Scotland, Northern Ireland, 1 in 16. And Scotland, 1 in 13 people. So this is a very high prevalence. 7.54% of the population infected in that single week. There's still a lot of this around. Now let's look at some of the graphics that can help us make sense of this fairly briefly. Here's the overall situation. Infections remain at a record high level, so they're kind of plateaued off there a bit. Now, I do believe from the COVID symptom tracker data that it's probably starting to go down a bit now, but this is always a bit out of date, but it is very accurate. Hospital admissions increased slightly, deaths increased slightly. Plenty of adults have had 3 doses. Virtually everyone has got antibodies, 98.8%, and social distancing remains low. Basically, people are behaving as if this pandemic's gone away, which is probably the right thing to do. But interesting that people don't seem to be worried about this anymore. Social distancing, a thing of the past. Mask wearing, in England at least, basically a thing of the past. Now let's look at the symptoms here that we're getting. These are Office for National Statistics symptoms. Loss of taste, that's gone down a bit. Loss of smell's gone down a bit, but still a prevalent feature. Fever, cough, shortness of breath, sore throat, fatigue, headache, muscle aches, abdominal pain, diarrhea, still some diarrhea there, nausea and vomiting, and asymptomatic, around about the 35%, 40% mark at the moment. So interestingly, that doesn't contain the most common feature, actually, which is a runny nose, according to the COVID symptom tracker data. Most of these patients are presenting as common cold type symptoms. But let's carry on with this review. England, so here we see the number of cases, percentage testing positive. Has it levelled off? Probably. Will that be down next time the Office for National Statistics does a review? Yes, that will be down, because we know that from the COVID symptom tracker data. So what we're looking at here is the peak. That is the peak that we are looking at now. I think we can be fairly confident about that. Scotland, likewise, started going down already in Scotland, which is good to see. Again, based on national survey data. Now, this is BA2. And this is BA1, so 7% now BA2, 0.6% BA1. So exactly as we predicted, BA2 has essentially displaced BA1 Omicron. Both Omicron, of course, very similar amount of illness and hospitalisation generated, but of course increased transmissibility of BA2, why it's become more prevalent, why we've got so much around, so much infection around at the moment. So there we go. Quite clearly, BA2 has taken over, and it took over really quite a while back. But earlier, late February, it took over as the most dominant feature in England. Scotland, similar picture. 6.8% now BA2, 0.6% BA1. And it's a similar picture in the other parts of the United Kingdom. The only exception is Northern Ireland, where BA2 took over earlier than other parts of the United Kingdom. But as we know, BA2 is becoming the global dominant strain now. Now, this graphic's useful because it shows us the consistency between the Office for National Statistics data in blue here, and the real-time assessment of community transmission, the REACT study, which is now finished, of course, but it shows that, so there's a REACT, every time there's a REACT study point, it's fairly similar. Completely separate survey, done in a completely separate way, but giving very comparable data, which of course is always reassuring. Infections in age groups, so slight decrease in the 50 to 69, and a slight decrease in the over 70s. And of course, the reason I put these up are these are the people that are most likely to require hospitalisation as a result of their infection. So again, I think we can be fairly sure that hospitalisations, at least people suffering, being admitted because they have COVID, a symptomatic COVID, is going to go down. More on hospitalisations in a minute. Let's do this in order. 1.7 million people in the UK were experiencing self-reported long COVID. Now, this is disappointing because I had hoped that during the Omicron period, the incidence of long COVID would go down, but it hasn't. So Omicron from this appears to be producing as much long COVID on a population level as Delta did. But of course, there's way more infections with Omicron. So I think we can fairly safely say that Omicron is less likely to cause long COVID because way more people have Omicron. So if you take 100 people with Delta, more of those will get long COVID. If you take 100 people with Omicron, less of those will get long COVID from this data. Because although there has been an increase, there's been a disproportionate increase in the sheer numbers, the sheer massive prevalence of people with Omicron. But I'm not going to pretend that's not disappointing. It's a lot of people. It's 1.7 million people in the country with some long COVID as of the 5th of March. Hospital admissions still going up slightly, but we do believe are levelling off. Now, there's a major problem with the data here from the Office for National Statistics, and it's not differentiating between people admitted because they have COVID, with for COVID because they have COVID and they have symptoms, and those that are incidental admissions because there's so much COVID in the community. Of course, we saw this in South Africa. We've seen this everywhere when the huge amount of people in the community with Omicron, therefore, of course, the people admitted to hospital are coming from the community. So more are coming in. And we believe, the Office for National Statistics doesn't give this, but we believe about 58% of admissions with COVID into hospital are incidental. And the smaller proportion are admitted for reasons of COVID. But of course, that still causes a lot of segregation issues in hospital, having to take infection control precautions. The numbers in intensive care, the sickest numbers, remains really quite low and has done so for a good long time now, since the start of Omicron, which is good news. Nevertheless, still some strain on hospitals, although manageable. But of course, the big problem with hospitalisations is we've got this delay of millions of people waiting for treatment. So even though we might manage on a day-to-day basis, got this huge backlog that needs to be addressed, which is causing serious problems. And we have noticed that there's some studies show already there's going to be an increase in deaths from things like cancer as a result of cancelled appointments. And this could be really quite significant. Cancelled appointments, delayed appointments, difficulty accessing treatment, all of these things. So still a problem, no question about that. What's next? Oh yeah, infections, hospitalisations, and deaths. So we see infections pretty well across the age group. Hospitalisations, of course, greatly disproportionately in the older groupings, and indeed deaths greatly disproportionate in the older age groups as well. That's the graphic for deaths. That's the alpha wave. This was the Delta wave. This is the Omicron wave. This was the original Wuhan virus wave. So we can see deaths now much, much lower. Good news. Again, another graphic showing deaths. Proportion of deaths where COVID-19 was the underlying cause of death was down. So these are the proportions of deaths. This is England and Wales, where coronavirus was the actual cause of death. So we see now that deaths from COVID, as opposed to deaths with COVID, down to about, what, 60% there. So while people are dying with COVID, fewer people proportionately are dying. Sorry, while people are dying with COVID, fewer people proportionately are dying from COVID. So, in other words, they're dying of other things and just happen to be infected at the time of the writing of the death certificate, at the time of death. This is death certificate data. So good that this is going down, indicating that all this bit here, all the remainder here are people that died with COVID infection incidentally, whereas these ones, the 60 or so %, died from the COVID more directly. Now, this figure here is actually in young people, aged 12 to 29, and it's the estimate of death after vaccination. Now, they've put this graphic up from the Office for National Statistics, and I believe they put it up to try and reassure people that the vaccine is not killing people in the 12 to 29-year-old age group. But it's also showing it's not saving any lives either. So why are they having it could be asked. So basically we're seeing, I mean, this is basically noise around the no difference line. And I think that's the end of the particular slides I wanted to show just now. So let's just reinforce some of the main points there I wanted to stress that tell us interesting things. People were more likely to test positive in the 2 weeks up to the 26th of March if they. So remember, these are people that were more likely to test positive, and this is quite tricky because it kind of goes into negatives and double negatives, like I ain't not going nowhere. But we'll try and get it right. So people most likely to test positive in the 2 weeks up to the 26th, so more likely to test positive. So people are more likely to test positive if they've not previously been infected with COVID-19, obviously, because they would not have natural immunity. And this is showing us the benefit of natural immunity. So I'm very pleased to see this statistic here. More likely to test positive if they've travelled abroad in the last 28 days. Now, I don't believe that this is because people are picking up abroad. It's because they're on aeroplanes and airports. Airports can be completely crowded. Aeroplanes, of course, you're in some kind of aluminium tube way up in the air. OK, they've got filters and all this kind of stuff, but you're still pretty close to other people. So I believe that's mostly transmitted during the transit process rather than these horrible places abroad that are crammed full of infection. I think that's the more likely scenario. More likely to test positive if they're of white ethnicity. So white people, ethnic white people, more likely to test positive. Quite why that would be, is it because other ethnicities have already been more commonly infected and therefore more likely to have natural immunity? That's possible. We don't know from this data, but it's possible. Worked outside the home for 2, 3, 4 days a week. Well, of course, working from home, you're less likely to come into contact with people. That was pretty obvious. Had not been, so people were more likely to test positive if they've not been living in a multi-generational household. So if there's just husband, wife and one child or whatever it is in the household, then they are actually more likely to test positive. And again, I think what's happening here is we looked for quite a long time at this. And the people that were living in multi-generational households were getting infected more readily. Now you're more likely to become infected if you're living in a single generation household, in a more nuclear sort of family. And I think this means that the infection has spread widely through multi-generational households and again generated quite a lot of natural immunity. So I see that as a remarkably encouraging feature. Quite pleased with that. Men were more likely to be positive than females. Not quite sure about that one. We're not impacted by disability. Again, maybe more disabled people have already been infected. Is that the case? Don't really know about that one. Had not been in contact with hospitals, so more likely to test positive if you'd not, this is the double negatives, not been in contact with hospitals. So in other words, contact with hospitals from that would appear to be protective, which of course is ludicrous, but that's actually what it's saying. So more likely to test positive if you had not been in contact with hospitals. Again, I think indicating there's just been a lot of workers in hospital already infected, and there's probably quite a lot of herd immunity, community immunity, natural immunity, whatever you want to call it. People get all annoyed about me and say we're never going to reach herd immunity. And I think that's true because the disease is becoming endemic. So when we say herd immunity, we're not really meaning that the disease is going to go away. We're going to mean it's become inconsequential and endemic. So when we say herd immunity, we are meaning the presence of widespread immunity, meaning the disease severity goes down dramatically, which to me basically is pretty well as good as herd immunity. Okay, it would be nice to eradicate it altogether, of course, but we know that's no longer possible in the next good few seasons. People are more likely to test positive if they lived in less deprived areas. So more likely to test positive if they lived in less deprived areas. So in other words, living in a deprived area, again, appears to be protective, which we're not saying, but again, probably because the infection's already spread widely in the more deprived areas. So I hope I got all my double negatives right on that one. Interesting, though. I mean, okay, that's thinking out loud to some extent. But there you go. We can only try and make sense of the data that we are given. This is important. Reinfections. Reinfections were 10 times higher with Omicron variant period than the Delta period. So reinfections, of course, people that have been infected before getting infected again with Omicron. Reinfections. Between July 2020 and the 20th of March 2022, people were more likely to be infected if they were. Well, that's a pretty long time period, I must say, so I'm not quite sure how much this data really means, but we'll give it because the Office of National Statistics does. Were unvaccinated, yeah, okay, but how much of that is current and how much of that was in earlier stages of the infection was simply not told, so it doesn't actually tell us much. Had a milder primary infection with a lower viral load, this does indicate that people that were more symptomatic were generating higher levels of immunity, or at least more longevity of immunity. But of course, if you've had a minimally symptomatic infection, you could well have had a couple of asymptomatic infections since then, or an asymptomatic infection since then. So again, I'm not sure it's really telling us quite that much, really. Younger people more likely to be infected, probably due to social behaviour. Older people tend to stay at home more, and again lived in more deprived areas, more likely to get reinfected. Now, the self-reported long COVID, this is a concern. As of the 5th of March, 1.7 million people, that's 2.7% of the whole population complaining of long COVID. This is a lot of people, and it's going to have a significant impact on well, everything in society, potentially. This is a lot of people to have long COVID symptoms. 69% of those for at least 12 weeks. 45% of those symptomatic for at least a year. So quite a lot of people there symptomatic with long COVID for at least a year. What were the most common symptoms? The main one is fatigue. 51% complain of fatigue. Ongoing shortness of breath, 34%. Loss of smell, 28%. Muscle aches, 24%. And adversely affected day-to-day activities in 67% of those people. Long COVID is more common in the relatively younger age groups. So the very young people and the older people getting less long COVID. I would imagine the reasons for this are immunological. People aged 35 to 49 often have very active immune systems, although there again, so do people in the late teens and early 20s. So we don't really have an answer for that yet. More information required. Long COVID more common in females. This is a emerging trend. Females more likely to have long COVID than males. More long COVID in more deprived areas, people working in social care, teaching, education and healthcare, more likely to have long COVID. No definitive answers as to why. People that have activity limiting health conditions or disability, again, that's not too surprising that they're more likely to have long COVID. 1% of primary age school children, 2.7% of older age children. But that is at some point since March 2020. So that doesn't tell us how many get better. So again, these aren't particularly useful statistics because they kind of tell us about a whole time period rather than what is happening now. So there's part historical data in that, which is less interesting to me because it doesn't tell me what's going on with health now. Hospital admissions with COVID and admissions for admissions with COVID and admissions for COVID not differentiated. Why not? Why is this data not given? And the other data that's not being given is the amount of hospitalizations in people that have had vaccines, infection without vaccination and infection with vaccination. And again, this data would be simple to give. Then we will be able to differentiate the amount of protection being given from vaccine alone, from natural infection alone, and from hybrid immunity. But from the Office for National Statistics data, for all the money we're spending on this data, we are not told that. And to me, that would be the most fundamental question. Is natural immunity working better to protect against hospitalizations than vaccination? What about vaccination and natural infection? We don't know. Why on earth are we not being told this? Why is this fundamental question simply absent from the data? Are the Office for National Statistics hoping that we simply will not realise that we're not being told this vital piece of information? I don't know. But it's very, very frustrating that we don't know this. Risk of death in Omicron times. Risk of death in Omicrons. So 67% lower than in the Delta time. Now, this is due to the reduced pathogenicity of the Omicron variant, because in the Delta time, vaccine levels were high. Now, a lot of vaccine have been a long time ago now in the UK. So, in fact, protection from the vaccine has somewhat waned, and yet risk of death from Omicron still 67% less. So I think we can be fairly clear that Omicron is less pathogenic, less likely to cause death than Delta. This is partly due to immunity, but not really, because the immunity was there in the Delta time. So this is due to the fact that the Omicron is less likely to cause death than the Delta. I think we can be fairly clear about that as well. It's interesting the way that things are clarified with time. No evidence of a change in the risk of death following COVID-19 for vaccine in young people. That's the slide that we showed. So they seem to put that on to show that vaccines are not killing young people, but it also shows that there's no evidence of a change in the risk of death following vaccination in younger people. So why vaccinate them if it's not really protecting them? And we know they're very unlikely to get hospitalizations and severe illness. So after vaccine, for 12 weeks, in the 12 weeks after vaccine, there's no difference in the death rate in young people. So why have an intervention that's going to make no difference to the death rate? I really don't get that, unless I'm missing something. But that's direct quote, no evidence of a change in the risk of death following COVID-19 vaccination in younger people. So there we go. Right, just one more thing, then we're done this one. COVID-19 mortality rates, lowest for those with 3 vaccinations. OK, we'll accept that. The risk of death involving COVID-19 has been consistently lower for people who've had a 3rd vaccine dose. That is true, although not, it would appear, in those aged between 12 and 29. Not in that group, it would appear. So presumably, the Office for National Statistics is talking about older age groups here, or the population as a whole. Perhaps they're talking about the population as a whole, in which case it is most certainly true. People who had received a 2nd dose of vaccine had a higher risk of death involving COVID-19 if their 2nd vaccine dose was more than 6 months ago, compared with those where it's less than 6 months ago. indicating the protection against death if you've had 2 vaccine doses is waning. Definitely waning. Disappointing, but vaccine protection is waning, meaning we can't rely on vaccines. Okay, the 3rd dose is going to help for a period of time, but the protection that vaccines give, if you've only had 2 doses against death, is waning. Disappointing. Hopefully that will be more than compensated for by the natural immunity that's being generated by the Omicron and the BA2 Omicron wave as we speak. Briefly, antibodies. This is the last thing. Antibodies. Antibodies. This is due to infection or vaccination. Now, how hard would it be for the Office for National Statistics to do both types of antibody test, looking at the spike protein and looking at the core proteins from other parts of the virus which are not generated by vaccination? They could easily differentiate between immunity from natural infection and immunity from vaccination, but they do not do so. Again, why is this not being done? People need to write to politicians about this and say, why are we being kept in the dark about the effect of natural immunity? Why is the Office for National Statistics, that we're spending millions of pounds on this survey on, saying nothing, telling us nothing about this? It would be so easy to test for both. They've got the blood anyway. Why not test for both types of antibodies? Why don't they do that? Why are we being kept in the dark about natural immunity? It is completely unacceptable. Completely unacceptable. And yet we have to accept it because we have no choice. But it's ridiculous. Why aren't we told that? They just say it's caused by infection or vaccination. Well, wow, thank you, ONS. We didn't know that. We want to know the difference between the two, but hey, you are not allowed to know. The information is great, but it only tells us what it tells us. What we really want to know, we're not told. Why not? This would be easy to do. It's almost as if there's some government conspiracy to keep the whole thing about natural immunity in the dark. Why would they want to do that? Of course, there's no government conspiracy. We're not conspiracy theorists on this channel, are we? But why don't they tell it? Why don't we have this information? It would be so easy to do. Anyway, the antibody rates, of course, are basically 99%. But is that through? How much of that is through vaccine? How much of that is through natural immunity? How much of that is through hybrid immunity? Sorry, people, you're not allowed to know. You'll just know what I see fit to tell you. Very disappointing situation. Now, I'm just going to go briefly. If some of you that have been following the Community Health Project we sponsor in Africa, the channel was able to send some money to buy some land in Africa. We're building a medical facility there, but we haven't got the funds to do that yet. So rather than the land sitting there doing nothing, it's being used to feed the local population. I'm so glad we've got this land, because if not, it could have been bought up by people who would use it for commercial crops. Whereas what we're doing now is we're planting beans for the local people. And let's have a quick look at Wafafa's report on bean planting. Beans, of course, so nutritious. And I think he's planting maize as well. So thanks for the report, Wafafa. Just play a few minutes. Great stuff from Africa.
Welcome to today's video. I'm in the village on our land for the facility. As I told you last time, we agreed to put in some crops, and today they are planting. We are actually planting beans. We already put down the maize, and now today they are planting the beans. So I'm going to be here for the whole day. You can see these are the holes that they dig to plant beans. Of course, different styles of farming everywhere. This may not be a perfect one, but it's the one that is used in the village here. So though we may change to better farming methods like some people suggested, but this is the one they know. So because of little time, we firstly wanted to put seeds down. So they're planting beans. Here is one of my mothers. She's putting the seeds. These are the beans that we are planting. Yeah, they look nice. And what happens, they first put, some people will be digging holes, and then some put seeds, and then some people will close. They are using direct. That is how they do it here. I don't know how they do it where you are, but that is how we do it here in Uganda. Actually, let me say in most parts of Uganda. Yeah, so that's a process. Yeah, of course, my mom is right there. Say hi.
Hi too.
Yeah, so what are you doing?
I'm weeding. What am I doing? I'm planting.
You're planting what?
Beans.
Hey,
Yeah.
Are they good?
They are good. Good quality.
Good quality.
Yeah.
You expect that we shall get here enough food to feed our workers?
Yeah.
So beans, we expect a lot of beans. I think you've seen her.
Yeah.
Yeah, I don't know if we resemble. Oh, sorry. She's here. This is my mother.
I'm the one.
Yeah. So yeah, so guys, that's the issue. We are doing the planting. I thank you for all the support that you've been giving us. People who have been sending in several donations that are really important. People who bought me coffee on Buy Me a Coffee, I really appreciate. And people who are still buying me coffee. Yeah, coffee is dangerous for our health if we take too much, but not the one you're buying. This one, the more you buy, the more it helps me. And then also people who are on Patreon, thank you very much for your dedication. You've really been so supportive. We can rely on that money to make plans ahead of us, because we expect it monthly. So thank you very much for donating, and for all our new subscribers who came due to COVID-19 updates.
There we go. Thanks for that, Wafafa. Do watch I'll put the link, and of course you can watch the whole thing on Wafafa's channel. Good to know that money that we've raised through this channel is doing that work there. And of course, if you want more information on Wafafa's channel, you'll see a lot of his medical work as well. But it's basic community support work, absolutely vital. And of course, always good to see the whole family working together. Didn't get what they were doing there with the feet, but they've obviously got it worked out, so I'm not going to criticise it. So thank you for watching.